Angina is most often a symptom of a heart problem called coronary heart disease or coronary artery disease. Your heart pumps oxygen-rich blood to all parts of your body. Your heart needs a steady supply of oxygen to do its job. Coronary arteries bring oxygen-rich blood to your heart. These important blood vessels are located on the surface of your heart. In a healthy heart, blood flows freely through the coronary arteries. The blood brings oxygen to the heart so it can work properly. In coronary heart disease, the coronary arteries become stiff and narrow, so less blood and oxygen flow to your heart. After exercise or emotional stress, low blood flow can lead to angina, pain or discomfort in the chest, arm, shoulder, neck, back, or jaw. Angina that keeps coming back over time is called chronic stable angina. It is most often relieved by rest or nitroglycerin. A clot in a coronary artery can severely lower blood flow. This can lead to more severe angina that may come on at rest and does not go away with rest or nitroglycerin. This is called unstable angina, which requires immediate medical attention. In summary, when blood flow is reduced, your heart does not get as much oxygen as it needs. This lack of oxygen is what causes the pain and discomfort of angina. If you have coronary heart disease, angina is the way your heart tells you it needs more oxygen. Talk with your cardiologist if you have questions about angina.
A heart attack happens when blood flow to part of the heart muscle is blocked. The blockage harms part of the heart muscle because it is no longer getting oxygen from the blood. Most heart attacks are caused by a blood clot that blocks one of the coronary arteries. Occasionally, a heart attack can be caused by a spasm or tightening of a coronary artery. Coronary arteries are the blood vessels that supply oxygen-rich blood to the heart muscle. In coronary artery disease, the inside of the coronary arteries narrow and harden because of the buildup of fatty material called plaque. Blood flow to the heart muscle is decreased. If the plaque cracks or breaks open, a blood clot can form on the surface of the plaque. The clot, also called a thrombus, can completely block blood flow in the artery. Once the flow of blood is blocked, a heart attack will happen when a part of the heart muscle becomes damaged. The heart may not be able to pump blood throughout the body very well. This can cause chest, arm, back, or jaw discomfort or pain, shortness of breath, or other symptoms. After a heart attack, if the blockage is not treated and removed within a few hours, the damaged heart muscle will begin to die and be replaced by scar tissue. This heart damage may not be obvious or may cause severe and long-lasting symptoms because the heart cannot pump blood well. Another less common cause of a heart attack is a severe spasm or tightening of a coronary artery that cuts off blood flow to the heart muscle. Spasms can occur in people with or without coronary artery disease. Just as clots may do, spasms can completely block blood flow in the artery. Once the flow of blood is blocked, a heart attack will happen when a part of the heart muscle becomes damaged. The heart may not be able to pump blood throughout the body very well. This can cause chest, arm, back, or jaw discomfort or pain, shortness of breath, or other symptoms. After a heart attack, if the blockage is not treated and removed within a few hours, the damaged heart muscle will begin to die and be replaced by scar tissue. This heart damage may not be obvious or may cause severe and long-lasting symptoms because the heart cannot pump blood well.
Heart attack or myocardial infarction is caused due to coronary artery blockage. Coronary arteries are the blood vessels which supply the heart with oxygen and nutrition. Over time, the inside of these arteries develop fibrofatty plaques of different sizes. These plaques are made of cholesterol and other substances floating through the bloodstream, such as inflammatory cells, proteins, and calcium. Many of the plaque deposits are hard on the outside and soft on the inside. The hard surface can crack or tear, exposing the soft, fatty inside. When this happens, platelets come to the area, and blood clots form around the plaque. The artery narrows further, and in turn there is less room for blood to flow through the arteries. Finally, this results in the occlusion of the coronary arteries, resulting in the death of the surrounding heart muscles. The patient experiences tightness, heaviness, or constriction in the chest.
As soon as you quit, that better you be.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. The lower left chamber of the heart, called the left ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster, and the ventricle may increase in size, becoming an even less effective pump. When the kidneys sense the reduced blood flow, they attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
Implantable pacemakers and defibrillators are devices that apply electric shocks to maintain the rhythm of the heart and, if necessary, restart it. As the technology improves and the list of treatable conditions grows, the number of devices being implanted is increasing steadily and now exceeds 500,000 a year. The heart is made up of 4 chambers, 2 atria and 2 ventricles. On each side, the atrium is connected to the ventricle by a one-way valve. Blood is pumped as these chambers contract and relax in turn. The beating of a healthy heart is regulated by electrical impulses. The sequence begins as the atria fill with deoxygenated blood from the body on the right and oxygenated blood from the lungs on the left. An electrical signal from the sinoatrial node then causes the atria to contract, forcing blood into the ventricles. The electrical signal is then picked up by the atrioventricular node and directed into the Purkinje fibers in the ventricle walls, causing the ventricles to contract. And the blood is then pumped through the pulmonary valve on the right to the lungs and the aortic valve on the left to the rest of the body. These valves close and the cycle then restarts. When the sinoatrial node fails to function correctly, an artificial pacemaker can be fitted to help regulate the heartbeat with small, evenly timed electric shocks. This involves implanting electrodes into one or more of the heart's chambers by inserting leads into a vein near the collarbone and implanting a device called the generator just under the skin. For more severe heart conditions, an implantable defibrillator, or ICD, can be used, which is also capable of sensing a stopped heart and delivering an electric shock powerful enough to restart it. For some conditions, an even more sophisticated device, called a CRT-ICD, can be implanted. This uses a third lead inserted into the left ventricle to resynchronize the ventricles when necessary. However, all these leads can cause problems of their own. Patients with ICDs have a 20% chance of a lead failure within 10 years, and replacing leads can require open heart surgery in about 2% of cases. This has resulted in several efforts to develop new pacemakers that do not depend on leads inside the heart. One design, the subcutaneous ICD, places the lead just outside the heart under the patient's skin. And wireless designs are now being developed that may eventually do away with the need for leads altogether.
It is gently and easily deployed over the thrombotic lesion by retracting a protective sheath, and because of its inherent design and properties, it exhibits no recoil. As spasm is relieved, the vessel diameter increases, and the stent follows in expansion and continues its scaffolding of the artery. Finally, as the thrombus dissolves, the stent expands further to absorb the gap left by the dissolving thrombus, thus maintaining a perfect apposition throughout the remodeling process of the vessel. This allows the free mesh to cover the side branch ostium. The wide opening provides uncompromised access to the side branch for optional further treatment. The shape memory properties of nitinol make the disconnected ends return to their initial position and safely appose to the vessel wall.
Myocardial infarction, commonly referred to as heart attack, is the sudden death of part of the heart muscle due to loss of blood flow. This occurs when one of the coronary arteries, the arteries that supply blood to the heart, is blocked. The blockage is commonly due to atherosclerosis, cholesterol plaques or fat deposits on the wall of blood vessels. As the plaque builds up, the vessel becomes narrow, restricting blood flow. Under stress, the plaque may rupture. This triggers formation of blood clot on top of the plaque, leading to complete blockage of blood flow. When this happens in the coronary artery, the downstream patch of the myocardium dies from lack of oxygen. Weakened heart muscle may disrupt electrical activity of the heart and subsequently cause cardiac arrest. Coronary angioplasty is a non-surgical procedure used to open narrowed or blocked coronary arteries. It can also be performed as an emergency treatment for myocardial infarction. The first part of the procedure is to localize the site of blockage. This part is called cardiac catheterization. A guiding catheter is inserted through the femoral artery at the groin and threaded all the way to the aorta. The tip of the catheter is placed at the beginning of the coronary artery to be investigated. A radio-opaque dye is injected through the catheter into the coronary artery. This enables real-time visualization of the artery using X-ray imaging. A narrowed part of an artery would appear as a bottleneck on an X-ray image. After the location of narrowed artery is identified, angioplasty can begin. A guide wire with a deflated balloon is inserted and pushed to the location of blockage. The balloon is inflated to crush the plaque. At the end of the procedure, the balloon is again deflated and removed together with all catheters and guide wire. In some cases, a stent is inserted together with the balloon, inflated, and left in place of the plaque to keep the artery open permanently.
Percutaneous coronary intervention, also known as coronary angioplasty, opens narrowed coronary arteries. A small, hollow tube called a catheter is inserted into an artery in the groin or arm and threaded to the affected artery. A thin, flexible metal wire is then advanced through this tube and past the site of blockage in the artery. A second, smaller catheter is then inserted over the wire and threaded to the same artery. When it reaches the narrowed area, a small balloon on its tip is inflated to reopen the artery and flatten the blockage into the artery wall, while at the same time stretching the artery open to increase blood flow to the heart. Both catheters and the wire are then withdrawn. About 70 to 90% of coronary angioplasty includes placement of a stent, a wire mesh tube that holds open weakened arteries. The stent may prevent re-narrowing after an artery is widened, and it stays in place permanently as the blood vessel lining heals over it.